are key global issues for more than 30 years, as they have serious repercussions. No measurement have been done to assess the situation nationally before. In addition, expanding emergency departments and adding more beds have never succeeded in eliminating waste and targeting root causes of this problem. This presentation will share how the Ministry of Health in Kuwait is addressing the problem of emergency department overcrowding as a part of its national project to improve patient flow in emergency departments. I'm Hussam Al-Amir, a physician and a quality specialist, and I'm leading the Ministry of Health team to improve the emergency department flow nationally. So, why waiting in the emergency department is an issue that should be tackled. In his article, My Right Knee, the well-known Donald Berwick identified waiting amongst other manifestations of low-quality service. Emergency department overcrowding and increased length of stay create serious threatening to quality and safety. They increase patient mortalities and morbidities and are associated with low patient and staff satisfaction. They also affect the leave without being seen and ambulance diversion rates. Kuwait is a high-income country located in the Middle East. The nation has a population of 4.4 million people as of 2019, of which around 3 million individuals are expats. The healthcare system in Kuwait is based on the National Health Service model. Kuwait has 7 decentralized health regions. Each health region contains only one secondary hospital. Emergency health services are mainly provided at the secondary level through 6 general hospitals. Since the beginning of the ongoing SARS-CoV-2 pandemic, the 7th hospital has been converted to exclusively manage patients with COVID-19. Impacted by this global pandemic, the emergency departments throughout the nation have been transformed and our staff are suffering from burnout. After the assessment phase of this project, we put the project on hold because of this situation. In 2014, we used to have patients receiving their treatment on chairs and trolleys in one of the 6 emergency departments. It wasn't unusual to see this situation continues for days at that time. So guided by my published work on assessing the emergency department overcrowding situation in one hospital, we assessed the situation nationally. After piloting, we collected data in respect to the timing of providing services to emergency department patients. After analysis, we found that there is an identified pattern of patient visits to emergency department. This pattern can help us to predict number of patients at any time. However, our staffing ratios were not aligned with this pattern. We created an artificial variation in our capacity. This demand/capacity mismatch was the first cause of emergency department overcrowding. Further analysis revealed that the number of patients who stayed more than 6 hours in the emergency department represents only 9% of the total number of patient visits to emergency department. However, their cumulative length of stay represents 30% of the total length of stay of all patients. Moreover, their boarding time, the time since the admission decision is taken, till the patient dispatch happens, this time represents 45% of the total boarding time of all patients, including those who stayed less than 6 hours in the emergency department. Because emergency department is manifested by a shortage of vacant beds in the emergency department, one may propose a simple solution for that, to add more beds. And as Henry Louis Mencken once said, for every complex problem, there is a solution that is simple, neat, and wrong. So why adding more beds is not only a wrong solution, but it also will worsen the situation. Look at the emergency department capacity as if it was a funnel where you add fluid into it. As long as the rate of adding fluid is bigger than the rate of draining, the fluid will accumulate, increasing the size of the funnel, will never reduce the fluid accumulated. You have to improve the drainage. Following the analysis of the timing of services provided to emergency department patients, an assessment of the current practices in Kuwaiti public and private sector healthcare organizations was conducted through the creation of an 18-question survey. For each of the 5 prioritized potential interventions, 1 or several questions were included to understand best practices associated with each specific intervention, which were in turn related to the 3 phases of patient flow through the emergency department: the input, throughput, and output. I must acknowledge the great effort of my colleague, Dr. Mohammed Barbahani, who did this part of the project. The surveys were mainly conducted through in-person hospital visits, which allowed for qualitative in-depth interviews as follow-up or expansion to the primary questions presented in the survey. Survey respondents were purposefully selected based on their knowledge and experience. We had a long list of proposed lean-based intervention. However, we selected these 5 interventions based on expert group opinion. 3 interventions will tackle the throughput and output components of the problem. The environmental assessment revealed that the bid management processes and respective ownership of each part of these processes varied widely between healthcare organizations. Also, the existence of a centralized admission office that was responsible for bid allocation was unique to private sector. For the majority of healthcare organizations, the bid management system was led by senior nursing staff. In all public sector hospitals, this process is carried out manually with a designated nurse, while none of the public healthcare organizations utilized IT system in the bid management process. The bid management system was incorporated into the existing health information technology of all private sector healthcare organizations. So we recommend these interventions. In the public sector hospitals, bid management responsibilities should be assigned to a dedicated person with a job title for a bid manager. Although this position doesn't essentially have to be created amongst nursing staff and could instead be granted to specialized administrative employee. Each healthcare organization should also create a supporting bid management team. This team should be multidisciplinary in nature, led by the aforementioned authorized bid manager, and should include nursing staff, physicians, administrative staff, a social worker, and an infectious disease specialist. Public sector healthcare organizations' current approach to bid management utilizing manual documentation can be improved to become more efficient and less laborious by utilizing daily available digital technology. To implement these overarching recommendations, a steering committee should be created within the Ministry of Health under the Ministry of Health Under Secretary for Technical Affairs. Finally, to increase chances of successfully implementing these interventions, we will assess the readiness of hospitals for lean management. Once the interventions are implemented, we propose to have these performance measures put in place to evaluate and monitor the successfulness of the new practices. Number of patients who stay for more than 6 hours in the emergency department or boarded for more than 45 minutes are to be reported monthly. Also, the bed crisis management protocols are there to manage situations when routine practices fail to achieve this. Hence, the incidence of activating crisis protocols reflects failure. We also propose 2 balancing measures to make sure that the introduced interventions didn't impact other parts in the complex system. By stating this, I'm reaching the end of my presentation. These are the references used in this presentation, and if you want to discuss any issue related to this presentation or the topic, you can contact me, and these are my contacts. And thank you.
Hello, everybody. I am Samuele Rivolta, and these mustaches are for the Movember initiatives. So give a look on Google for what it means. Let's start with the presentation. I am a medical doctor of the clinical management staff of ISST Santi Paolo Carlo, that is one of the biggest hospital agency in Milan. It's a great pleasure for me to take part to this session and to contribute to the 44th World Hospital Congress with this work, facing the COVID-19 pandemic emergency, the experience of two main hospital centers in Milan. Our work analyzed the experience of two hospital agencies in Milan that we call here H1 and H2, that lived the hardest part of the first pandemic emergency wave in Italy in 2020. As we can see here, since February 21, when the first autochthonous case of COVID-19 was found, the curve of positive cases started to grow with a rapid progression until the beginning of April. This meant a parallel and proportional rapid increase of hospitalizations, with a huge impact on emergency wards and intensive care units activity. Lombardy has been one of the most affected regions in this period, when the emergency led to significant organizational changes in hospital settings to ensure the best clinical and care pathway for patients and for the protection of healthcare workers. The aim of this study is to compare the activities and the outcomes during the first pandemic wave in two large hospitals and centers in Milan to find possible good management practice for future pandemic emergencies. We performed a qualitative and quantitative analysis of the hospital activities between February and May 2020. For the qualitative analysis, we used the WHO Rapid Hospital Readiness Checklist for COVID-19. This instrument explored the most important management areas for this emergency, and we applied it on the situation at the beginning of the first emergency wave and at the end of it. For the quantitative analysis on the right, we checked on one side the output data of COVID and non-COVID beds availability, proportion of low, medium, and high intensity of care areas, number of hospitalization and emergency rooms activity. And on the other side, the outcome data with the type of discharges and the case fatality rates. The results of the WHO checklist refer to the beginning of the emergency, so look up on the right, showed for H1 a good performance in patient management, rapid identification and diagnosis, and infection prevention and control areas, and the worst performance in surveillance and information management, risk communication and community engagement, administration, finance and business continuity, and the continuity of essential support services. The same analysis for H2 showed a good performance in occupational health, mental health and psychological support, and infection prevention and control. And the worst performance in leadership and incident management system, risk communication and community engagement, human resources, surge capacity, continuity of essential support services, and patient management. The same, both hospitals improved in most of the areas during the emergency, as we can see in the box down on the right for June 2020. The quantitative analysis described a similar hospital capacity between H1 and H2, with more or less 1,300 official beds available, 506 of which activated for COVID-19 beds areas by H1 and 353 by H2. The number of hospitalizations was of 1,437 in H1 and 1,077 in H2. The median age was lower in H1 than H2, 55 versus 65, while the length of stay was similar. In the end, the case fatality rate was of 15.4 in H1 and of 29.3 in H2. While the two hospitals registered a similar proportion of COVID-19 high-intensity care areas, showed here with the red line, H1 offered a significant higher proportion of medium instead of lower intensity care areas, where medium is represented with the yellow line and the low intensity care areas are represented with the green line. And this was exactly the opposite of what H2 made, with a higher proportion of lower intensity care areas. At the same time, the bed occupancy rate stayed under 100% in H1 throughout the period, while a saturation is registered in H2 in the peak of emergency. The analysis of the type of discharges showed a lower proportion of deaths in H1, that is the representation over the time of the case fatality rate seen in the previous slides. In both hospitals, the proportion of deaths significantly decreased during the period of emergency. A higher proportion of transfers, on the other side, was registered in H2. The discussion on the presented results could cover really a wide range of consideration, but we would like to focus on the evidence of the case fatality rate that showed a significantly different outcome for patients hospitalized in H1 and in H2. This may be attributed to some qualitative findings we analyzed, such as the best performance in H1 in human resources, search capacity, patient management, rapid identification and diagnosis, infection prevention and control, as well as in some quantitative findings, such as an earlier and higher emergency engagement and a higher level of intensity of care offered. These results should be considered for descriptive purposes only, as no inference analysis was performed. We can say that their interpretation cannot be considered definitive, also because there are several aspects that can condition them. First of all, the different role that the two hospitals played at a strategic territorial level. H1, in fact, has always been the reference for infectious disease emergency in northern Italy, and was the first to be alerted to the COVID-19 emergency. Secondly, the mortality data must certainly be corrected for the average age of the hospitalized people, in which H1 was significantly lower. In any case, concluding, this work offers a first attempt at retrospective analysis on the emergency period and highlights possible elements that can contribute in the future to a better management of these events, especially from a strategic and management point of view. Thank you for your attention.
Good morning, everybody. My name is Lidia Blanco Silvente, and I am a member of a health technology assessment team in the Catalan Agency for Health Quality and Evaluation. First of all, I would like to say thank you very much for your interest in our work. As the title said, I will be presenting supporting decision making from health technology assessment reports to an evidence synthesis tool. I would apologize because the primary authors of this work cannot attend the meeting. So in any case, if you have some questions regarding the synthesis tool that I will be presenting in this Congress, please you could address to the email that you have at the end of this presentation. So I would like to share the last definition of health technology assessment. So what is HTI? HTI is a multidisciplinary process that uses methods to determine the value of health technology at different points in its cycle. The purpose of HTI is to inform decision making in order to promote an equitable, efficient, and high quality health system. The procedure to evaluate a health technology is rigorous and systematic. We consider different methods to identify and provide the best updated evidence, but the systematic review is a design more frequently used in the HTI reports. To continue, what is considered a health technology? It is considered any intervention for prevention, diagnosis, or treatment from medical condition. It is considered also interventions to promote health, to provide rehabilitation, or to organize the healthcare system. For example, an intervention could be a diagnostic test, a device, a drug, vaccine, program, or a system. The aim of HTA is to provide the evidence about the value of a health technology in comparison with the alternatives existing in the clinical practice. The critical dimensions included in the HTA reports are safety, clinical effectiveness, cost, and economic impact. In some reports, it's also considered ethical, social, legal, and organizational aspects, as well as questions related with patients, with families, caregivers, or the general population. But the HTI, the traditional HTI reports have a limitation. The results are reported in a draft in which we describe the available evidence and its quality. But however, there are some barriers to make an impact of HCI reports on health system. In some fields, the evidence is extensive, so the results of the evaluation are large and extensive too. In the context to guide policymakers or clinical decisions, sometimes there is a need to take a decision quickly, in a short term. So in these cases, it could be useful to have a practical tool to highlight the key findings of HTI assessment. In a hospital context, management tools are used to plan their investment. A synthesis product of HCI reports, which summarize the key findings and recommendations for decision making, could be a useful tool to support decisions related to acquire or update health technology. So in this context, our objective was to develop a product to summarize the evidences included in a traditional HTA reports in order to help clinical decision making at different levels, included the hospital context. To achieve our objective, first of all, we elaborated a synthesis draft based on our knowledge as assessment team. And in this draft, we included the critical domains of HTA report. The second step was the validation of the synthesis tool. And for this validation, we contact with an expert group that involved stakeholders related with health technologies and key users who take decisions on health technology at hospitals. The group evaluated the use, the structure, and the content of 8 syntheses, came from 8 HTI traditional reports. We also elaborated different materials to guide the elaboration of the synthesis. And finally, we did a pilot test in order to know what is the practical use of the synthesis tool. So let's go to the results. And in this slide, you have the structure and the content of a synthesis tool. First of all, we have an ID that there is a synthesis tool of HCI report, the title, some information related with the type of studies included, what is the clinical content, the comparators, others. Here we have the HTI domain. Below, the summary of findings, some additional data. Here, the relevant outcomes for decision-making selected by professionals and patients. And at the end, some information related with the author, with the search strategy, the petitioner of HCI report, and others. So let's go with this section of synthesis tool that are related with the HTI domains. So related with the critical domains, we design a legend of colors and numbers to describe the effect of the technology and the quality of the evidence. Number 0 means that there is a lack of evidence for this domain. Number 1 in red means that the technology have a negative effect of any quality. Number 2 in orange, the effect of the technology is unclear or there were no differences in comparison with the alternative. 3 means a positive effect of a moderate quality. And number 4 in green also a positive effect of the technology of high quality. If you have more information about this legend, please you can contact with us because in this presentation we have some minutes. So let's continue with the next slide. Here you have the material that we use to guide the synthesis elaboration. Here we have the items included and related with internal validity and external validity and how we did the evaluation based on these items. Based on these items, we obtained the different evaluation for each domain. Here you have some synthesis published, but if you have more examples, please you can click in this link and you have all the synthesis published by our agency. Here you have 2 examples, as I said. First of all is a evaluation of robotic drug dispensing in hospital. And you can see you have here the legend. We obtained that the positive effect of safety, but some concerns about the cost and the clinical effectiveness. And in the second example, we have the Maldito for the diagnosis of resistance. It is a emergent technology. There was a lack of evidence for the vast majority of domains. So we evaluate the impact of this synthesis. We contact with different professionals involved in decision making. We obtained 18 answers, and the results were that the synthesis products are useful, and the vast majority answered that it's useful to update their knowledge. Apart, they use to obtain reliable information, and another part that they use the synthesis to make a professional decision. The synthesis is useful, but the vast majority needs to require to read all the HTI traditional report to obtain more information. But in general, all the participants recommend the synthesis product. So, to conclude, the synthesis is a useful tool to summarize the key findings of additional HTA reports. However, in some cases, the reading of HTA report is required to have more information. So, synthesis tool could be a complement of HTA traditional reports. Synthesis tool can facilitate quick access to standardized information, a supportive guidance for stakeholders involved in health technology investment or management. Thank you very much for your attention. And as I said before, if you have some questions, you can contact with us by this email. Thank you very much. Bye.
Good morning. My name is Soledad Romea. I'm the Director of Quality, Process and Innovation for the Vall d'Hebron University Hospital. Thank you for the opportunity to share our experience. Let me briefly take you through what I will present today. I will explain our model of clinical practice and quality management. The aim of this model is to add value to the patient, driving a cultural, organizational, and processes transformation. I have structured my presentation in 6 points. Firstly, I'm going to explain what is Vall d'Hebron University Hospital. Vall d'Hebron University Hospital is the largest hospital complex in Catalonia and one of the largest in Spain. This slide shows our data. The hospital combines the focus on complex services as a tertiary hospital with a dual orientation on the territory. We can provide a comprehensive care in all stages of life. So, why do we need to transform our hospital? Because we have external and internal challenges and problems to meet. The environment is complex and changing, and the healthcare expenses are growing exponentially. Aging, chronicity, and emerging diseases creates strong pressure on healthcare systems, and a new patient profile requiring greater participation in health-related decisions. In general, in the hospitals, we have traditional organization by departments and services that generate fragmented care. They are risk of incidents and adverse events related to patient safety, variability, overuse, and non-value practices. So then what goals do we want to achieve with our transformation? We want to achieve the quadruple aim goals: to improve patient experience, outcomes health, professional satisfaction, and to reduce costs. And in conclusion, that means increasing the value of care. So then how are we doing it? Well, our current model is the result of a long journey full of rights but also wrongs. In 2006, we implemented a new organization structured by process directions across the hospital. Later, in 2016, an organization based on a more advanced process model was developed. And currently, we need to advance. And the management hospital is promoting a new organizational model based on knowledge areas. What type of changes do we need to implement? Let me start with the organizational change. Then, I will move on to the way we work and how to improve clinical process. Finally, I will discuss the relationship with patients, professionals, and providers. Our overall aim here is to promote a great cultural change in our organization. Firstly, the organizational change. We made a matrix organization that combines knowledge of services and patient flow in clinical pathways. We are organizing departments and units in 28 areas based on health problems, for example, health area, and 4 transverse areas, for example, emergency. So far, we have also reorganized the inpatient units by 3 intensity of care: acute care, intensified care, and intermediate care. Moving on to how we work. We have designed an innovative methodology to improve processes. It integrates skills from the health sector, mainly clinical management or high-value care, and the other sectors, for example, lean or design thinking. A support team made up of doctors, epidemiologists, nurses, and engineers helps professionals to apply these skills in multidisciplinary workshops for each process. Flow and efficiency, safety, knowledge, innovation, teamwork, leadership, and continuous improvement are the keys of this methodology. My last point here is to mention the change in the relationship with patients, professionals, and other institutions. We are integrating patients with professionals into the same team. It's a wonderful experience to hear the description of a process from the patient point of view. On this point, I would like to stress the following. To be successful, our transformation must be led by healthcare workers in a bottom-up and top-down strategy. We need their co-responsibility, and we mustn't forget our relationship with providers. We would like to be partners so we can innovate and add value. So, I will share some actions and projects that we have implemented. Since 2015, we have driven 65 groups to improve organizational and clinical processes. One example is the surgical process. We set up multidisciplinary working groups to implement a new way of working. This work helped us to increase the activity and the surgery performance of operating rooms and reduce the rescheduling, the average pre-surgery hospital stay, and waiting list. Another example is the improvement of process stroke. We apply our improvement methodology, but in addition, we measure patient-reported outcomes. The main results were standardization of clinical pathway, better patient flow, clinical outcomes, and coordination with primary care. This slide shows some examples of safety projects. Our safety model is based in prevention, mitigation, and evaluation. We organize specific courses for the different areas to promote safety culture and best practices. We have developed a program for the first victim, the patient, the second victim, the professional, and the third victim, the organization. And we have created referral professionals in each area to manage any incident or adverse event notified. With this strategy, the number of notifications has improved from 340 in 2018 to 1,834 in 2020. Also, we promote a program to improve the appropriateness of clinical practice. One example is the project to improve the appropriateness in the prescription of oxygen therapy. In the initial analysis, we observed a great variability in the prescription with a low record of the optimum range of oxygen saturation and the required flow. A multiple intervention was implemented. It included mainly standardization of prescription, training, and modification of information systems to prescribe oxygen in the same way as other drugs. In the last evaluation, all indicators improved. This slide shows two projects developed to promote the innovation. The first example is the annual ideas contest called Joinovo. We reward the most innovative projects in 4 categories: patient safety, patient satisfaction, professional satisfaction, and sustainability. The second example is the Health Transformation Academy, an initiative financed by EIT Health and conducted by hospitals of the European University Hospital Alliance to innovate in training. The Academy offers online programs in leadership, innovation, and high-value care. Finally, let me summarize our lessons learned to develop the model. It's important to identify value from the patient point of view. Encourage an integral and comprehensive approach aligned with the strategy. Professional leadership. promote teamwork, make visible problems and learn from the successes and the mistakes, develop a sample-adapted methodology, maximize empathy with patients and with professionals, and finally, focus on standardization and continuous improvement. This is my email if you wish to contact me for more information. Thank you very much for your attention.
My name is Marco Enzitari. I'm the Director of Integrated Care and Research at Par Sanitari per i Virgili, a public company managing geriatrics, palliative care and primary care services in Barcelona. I am very glad to be presenting at the 44th World Hospital Congress about our 3 years experience of a geriatric hospital at home model implemented here in Barcelona. This is the outline of my talk. I will start from the need and the evidence, moving to our model, commenting our results, and finally mentioning how we did adapt or what happened in our model due to the pandemic, and finally I will comment on lessons learned. Why do we need to change our care model for older adults? This is because a high proportion of patients prefer to be treated at home. This was reinforced by the COVID-19 pandemic, of course. So we do have hospital at home models here in Catalonia, in Spain, and worldwide. This has been expanding during the last, I would say, 10 years or even more. However, this is the main model is responding to a classic acute hospital scheme, which is not suitable for older patients who usually need comprehensive, integrated, and different services at a time. We do have also different models described in the literature, also adapted to older adults with chronic diseases or acute disabling diseases. This is just a summary, but usually these models can be classified into step-down models, promoting early discharge from the acute hospital for a prompt return to the home, and also as step-up services, avoiding an unnecessary hospitalization in a classic bed-based service. Around 10 years ago, we started investigating on the hospital at home. We published, for example, this review on early supported discharge for stroke patients, providing holistic care and rehabilitation, and we highlighted which were the main key points of the model. Actually, we have to say that these models were limited to Northern Europe and were not implemented in Southern Europe, for example. Then we also worked at specific pilots. We piloted one first hospital at home with a team of Badalona, northern Barcelona, and compared the results of the patient attended with this model to similar patients attended in bed-based units. These were mainly responding to the step-down procedure attended by a model including geriatric rehabilitation in the hospital at home. And we could see that results were very similar with a shortened global length of stay. This year, an important randomized controlled trials was published from 9 hospitals in the UK, and this is relevant in terms of sites of the trial and shows that comparing to conventional hospitalization, the results are quite similar. but for example, institutionalization could be reduced and some clinical outcomes could be improved in the mid-long term. But in general, attending people at home is feasible and probably responds more to their own goal. So we wanted to implement an alternative to conventional intermediate care and geriatric rehabilitation at home. And we thought that this could be beneficial either for both the patient, providing more comfort, more contextualization of the rehabilitation and less hospital-associated complications, but also for the system, expanding the capacity of care and reducing possibly costs. This is how we function. We serve in these moments 2/4 or half the, let's say, of the city of Barcelona. Our target population are older adults with acute processes or exacerbation of chronic condition with secondary functional loss. We combine the two pathway, step up, step down, with the time-limited intervention. We work with an interdisciplinary team, also including professionals of rehabilitation, physiotherapists, occupational therapists, and also remote speech therapy, together with geriatricians, geriatric nurses, and social worker. We work following the principles of geriatric care, so with a multidisciplinary approach and a targeted plan. We provide basic hospital services with the coverage, which is like at the end 24/7, and we provide the timely visit after discharge. When we can, out of the COVID situation, we also like to provide a pre-discharge visit to generate a sense of trust with the patient and the family. Of course, we worked a lot on the preparation of the implementation of this team, training the staff, and providing local dissemination for advocacy and generating a need of this new resource. These are our results from December 2017 to July of this year. We attended 527 patients, mainly women with a high mean age, intermediate comorbidity, and half of them were living alone. 1/3 of them needing a caregiver or some type of support at home. They were mainly referred by the acute hospital, also 30% by primary care, and these are the main reasons of admissions. Mainly the compensation of chronic diseases, but also acute events like a hip fracture or a stroke, and the vast majority had some type of geriatric syndromes. The functional evolution in the unit between admission and discharge is positive, so they can get back, so they could recover some function to be able to live at home. And the majority of the patients stayed at home. Of course, we have to send some at the acute hospital, and some couldn't keep living at home and had needed to be institutionalized. Of course, the COVID-19 situation hit very relevantly older adults, not only in the terms of being affected by the disease itself, but also, of course, the whole system was reshaped to attend the COVID-19 needs. And there is a bunch of literature showing that, for example, the capacity of primary care to attend chronic disease was lowered, and even acute conditions such as a stroke were less prevalent at acute hospital. These are data either from Barcelona or from larger consortiums. On the other hand, we saw that our hospital at home was still very demanded and used. We had an increase of post-acute care in general, but also an important increase. If you can look at the slide, there is an important jump in terms of relative number of cases, for example, of post-acute stroke, also wounds care, and of course post-COVID patients were the new profile, whereas probably like programmed interventions such as orthopedic intervention reduce the need of attention by hospital at home. So in summary, we think that our geriatric hospital at home might be an effective alternative of conventional hospitalization in the real world. Both rehabilitative care is important, and in general, multidisciplinary work is a key component of our program. And of course, we need new research to investigate the impact on clinical complication and to support the idea that costs are really reduced with this resource. Thank you very much for your attention. This is my team. Of course, nothing could be possible without these people, and also the people, the professional working every day at the hospital and the hospital at home, of course. And for any possible need, I'm available at your disposal.